And we figure out solutions for the reason or solutions for the issue that's showing up in the data. And sometimes it's just, the patient's not compliant. But sometimes it's, I didn't screen the thoracic spine well enough, or I didn't look at, and so we come up with clinical solutions for these patients, and then for the next couple of visits, the clinician is just following what the committee said to do, and then we reanalyze it. So we're in a way, we're running down a similar pathway that you guys are. Ours is just, it's very data enabled, and it really represents our quality assurance program. So that's kind of how we're doing it. So I was very interested to see what you guys were doing with the spruce, that interactive thing. It just doesn't happen in clinical processes. It just doesn't happen. Everybody's just flying solo, thinking they're doing a good job. No one's keeping out. So anyway, congratulations on that. It's kind of cool. The examination gets a lot more complex, right? There are levels of complexity. And so I was only offering you what we suggest happens at a triage level, because there's 14 people sitting outside the family physician and nurse practitioner PA's office. You've got acne, cancer, GERD. You've got, by the way, if I think your lectures, I was paying a lot of attention, and I'm telling you, from now on, when I can't figure out a musculoskeletal condition, I'm looking at their tongue. I'm going right for that, because I gotta believe there's something there, right? No, that's right. That's right. I got them in the gown. I got the clothes off, and I'm going, get the tongue out. Get that thing out there. So back to answer your question, I'm suggesting at the basic triage level, look at extension, and if it gets more complex than that, then I would suggest you refer it over to someone who's had more extensive training. But the problem with physical therapists and chiros is this. They'll hang on to something like an alligator hangs on to a piece of meat, right? And they'll keep examining just the same way the cardio guys do, right? Let's do every test under the sun because someone's got chest pain. Did anybody stand back and listen to the fact that she's worse when she eats cold and hot food? First place to look is not cardiac. I'm not a doctor, but I do listen to the history, and I'm watching that going, what's the food got to do with it? Is there a simple little inexpensive test we can do first before we send him over to the ER, right? That was the first thing that popped into my head, right? And so it's along your line of questioning. There's a million things you can do, but the suggestion is this. What is the most likely source? It's mechanic, right? So let's start at where the odds are. Well, then if extension reveals 0, which is atypical, but it could happen, go the other way, flex them, right? And if you still nothing and you look lateral, there's still nothing, it's not mechanical, right? Because the beauty of mechanical conditions is as soon as you put load through them, something happens. You know what? It is a better approach than let's get an image. Right? But let's go to this. Can that be improved upon? That would be, to me, the answer is yes. Right? So I think that's the question. Can that be improved upon? Yes. So there's always this question of why do non-steroidals tend to help, especially when you know that only 2% are chemically dominant. And there is a number of answers in the literature. Some is placebo, some is, well, there's a natural history, and if they take it's time. So I'm not a doctor and I'm not a pharmacist, so I can't really comment on the non-steroidal a whole lot. But the general exercise thing, I can. Any clinician who is getting people to move with musculoskeletal pain is going to get a better result than someone who's not. So we know that. And so therefore the idea of let's try some general exercise, there's a little bit, there's value in this. But here's the problem. That patient that gets that general exercise, if we follow them and we just either converse or we look at the claims data a year from now, 60% are back in the system. And not only is that a problem, it's a larger problem than you think, because if a year later they've either recurred or still are having some suffering, you may not even realize it, but they've escalated. They've decided, you know what, I'm getting pretty frightened by this. My problem is not necessarily going away. I've already tried the doctor level and it's not happening, so I'm going to escalate. I'm going to demand an MRI, or I'm going to make sure that I get some type of surgical consult. When surgeons don't usually make a move without an MRI, and 50% of us have a disc herniation on our scan. And if it happens to match the side of pain, and I've had it for a year, they've failed conservative care, they're escalating. So I'm going to suggest this. 82% are green flag conditions. So movement is good, but in 82% there is one specific movement and load that is more mechanically advantageous over and above all the others. The first place I would look if I was you is in extension over a fulcrum at over 55 and extension in lying under. You're going to find a few, maybe 20, 25, or 30 out of 100 who actually start to improve fairly rapidly. Now, you're also going to find some that decline fairly rapidly, and that's indicative that you have a green flag condition, but you need someone who's had more training in this area on the conservative side. So you're doing a better job than some by getting them to do general exercise, but there's a 60% chance that within a year they're going to escalate care. when they follow very specific protocols based on the in-house examination. So once again, though, look, I'm trying to present sort of a generally best-in-class approach, right? So physical therapists, problem is in the variability. You've got some physical therapists you might have worked with very closely who are very specific in the things that they do and are getting some excellent outcomes. Same with chiropractic. But then that could be happening at your level, but then over here, you're finding that every time you send someone to a physical therapist, it's like a black hole. Like 6 months later, the family calls and says, have you seen my husband? We can't find him. And that's because they're in that physical therapy black hole. They're still doing their thing. And what conservative care clinicians tend to believe is, what I do, the worst thing that can happen is what I'm doing is innocuous. And what they don't realize is that no, if you're applying something as a clinician for more than 10 days to 15 days, and the patient does not see significant improvement, their psychosocial aspects start spinning, and they are going to escalate demand of care. And the second they get an MRI, you now have it's like a 5-to-1 chance that they are going to move towards a surgical environment. The second they get that MRI. And even if it correlates with the symptoms, here's the other part of this, even if it correlates with the symptoms, it doesn't necessarily mean that it is the cause of the symptoms. And even if it is, then it doesn't tell you what is the best approach. Just because there's I've had patients who have local back and buttock pain with a little tiny herniation on their MRI that correlates with their findings. I can't do anything with it. And then I've got another guy comes walking in, and they've got a raging sciatica, they've got a drop foot, they've got an MRI with a disc that's hanging down in the canal. 36 hours later, they're 75% better. You don't know, based on the MRI, what the outcome is going to be. That's the problem. All it does is create an incredible amount of fear. I'll be so bold to say is MRI has done more in destruction in terms of musculoskeletal disorders than it's ever helped. When we did a claims data analysis, we looked at whether a patient had an MRI or not. 29% of the population within the community had an MRI, and if they had an MRI, the cost of care escalated 5-fold, right? So 5-fold. So some would say, well, maybe they needed it. Well, hold on a minute. 2% of these people should be being operated on, and we're finding that it's about 14. Medicare says that 13% are being operated on. 13% should not have an MRI. No. So let's go layers. Okay, perfect. So what do? If you're in an environment where you don't have an organization like ours in support where we're working together, right? You don't have that. So first level, he's at least not imaging, and he's getting him to move. Next, a lot of conversation about don't be fearful of this, keep active, stay busy, right? So all the positive, right? That's not getting them to where you need to go. Now a referral to physical therapy is your next option. Have you formed a relationship with a physical therapist or a chiropractor that is actually getting results, has been able to show you they're getting results, has been able to show you those results, and you can trust them that they're going to be able to do this in less than 15 days? Because if they can't, then a referral to physical therapy, you might as well get ready, because you're going to get an image, and then you're going to get a surgical consult. That's the environment you're stuck in, right? Medicare is telling you, you guys got to fix this, but they're not giving you any further training. That's why I brought up that consensus for change. There's enough evidence now in musculoskeletal sort of crash and burn that the societies are recognizing we've got to improve the undergraduate education. But that solution is going to take another 15 to 20 years. And Medicare is asking you now, in fact, reimbursement for a lot of primary care organizations in 2019 will depend on what you guys are doing right now, 2017, 2018. So what's the worst case scenario? Of all the possibilities, what you're doing is better than sending for image and specialist consult. Next layer. If you've got a physical therapist or a chiropractor that can show you clinical outcomes and you can see results in at least 80% of the population within 15 days, you're in better shape than the next. An organization that standardizes and quality assures its clinicians around clinical outcomes, that's where you want to be. That's the best I can give you. And now I get it. You're in this situation. What the hell am I supposed to do? I can give you what our solution is, but it's not universal yet because the demand isn't there. That's all I can tell you. Yes, you got it. You got it. You know what I would suggest? I said if you're going to send them for MRI, you might want to get together with the orthopedic surgeons and put your business together. There's no doubt about it, because it goes up 5 times. Yeah, it's incredible. You guys are very nice. Thank you very much. Let's get out of here.